Hi everyone, I'm David Glazer with Fredrikson and Byron, and we're here for Compliance Revisited, the popular PBS show about compliance plans. A few announcements to start us off here. First off, our next webinar, which will be on November 13th, is going to feature Carrie Rosenberry and Briar Andreessen talking about electronic health records. Let's try that again. Negotiating electronic health record contracts. So all the stuff that you need to deal with when you deal with EHR things will be the topic next month. I assume it will be popular. The following month, we'll be doing our annual fee schedule and IPPS update. We don't yet know what we'll do in January. We like suggested topics. Today's talk is actually through suggestions. And actually, there have been a bunch of suggestions. One of them, we've received numerous suggestions to do some ICD-10 training. And at the moment, I don't think we're going to do that because it isn't exactly a legal topic, although it's certainly a health topic. But I wanted just to let people know we do have Ann Smith as a consultant here. And she does do a HEMA-approved ICD-10 training. And so if that's something that appeals to you, she can do train-the-trainer stuff. I don't think we're going to do a webinar on it. That might change. But if you're interested in that, you can always send me an email, and I'll hook you up with Ann, and she'd be happy to help. Just a couple more announcements. If you have let the HIPAA deadline slip by, don't forget there's a bunch of stuff. You can go to our SlideShare site, and Robert will right now be typing a link to the SlideShare site where our past 2 webinars on HIPAA training are, and we've also got the templates and things like that you can use. So if you find yourself behind the 8 ball, Briar Andreessen and Katie Ilton here can help you out. And then don't forget, not all, but the last year's worth of webinars are on SlideShare. I find the SlideShare site slightly difficult to navigate. We'll send you a link here. There's a link in the slides we'll come to in a while. But you can find things on there. We're going to be working on a user-friendly way to find our past webinars a little more easily. Final 2 points. I love questions. Some of the things we'll talk about in the talk today come from client questions. And so I would encourage you to ask questions at any point here. You type them in the chat box. Robert will whip them off and hand them to me, and we will send them throughout the presentation because we'll take them kind of as they come, I hope. And then finally, if the internet slows down over the lunch hour, if I start getting choppy, you can assume that I have not started to speak in tongues. It is the internet slowing down. Use the dial-in number that Robert has typed out. You can do that at any point. So let's get going. When it comes time for compliance, you've got a strategic plan, and you're going from A to B to C. And you can either wind up like Bill Gates or Martha Stewart. Stay with me now, people, because in step C, things get a bit delicate. Now, some of you are laughing at this joke because you've never seen it before, and some of you have seen this like 6 times, which brings me to an important point about the weird makeup of our talk today. There is someone on this presentation that I did a compliance plan for in 1995 when I was 5 years old. And there are some people who have admitted to never, ever having done a compliance plan yet. So we've got a wide range of understanding, so bear with me. Those of you who have heard this before, you know how bad I am at these talks, but you will hear some new things in there. But we're definitely going to be covering some of the basics for folks as well. It's going to be kind of a mix. One of the core principles of compliance should be simple. The system should be fair. I'm amazed at how often this core principle is overlooked. But as part of the compliance training, the first thing I want everyone to understand is that we're only going to keep money for care we actually provided. If we billed for something we didn't do, we're going to refund that money. But when we did work, the test is there a rule? And if there's a very clear rule prohibiting what we did, then a refund is probably necessary. But this is where things get nuanced. Rules and policies are different animals. There are federal rules in the regulations, and then there are a whole bunch of manuals that are policies. Policies aren't binding. And this is where lawyers, we earn our money, is to separate those things. If you violated a policy, there's a pretty good argument that you don't need to refund the money. One of the biggest challenges in any compliance program right now are figuring out what rules apply, because payers are entirely different. And when you're dealing with a private insurer, you have to look and see if you have a contract. If you don't have a contract, then you're working under industry norms, and you generally aren't going to have a duty to refund if you did the work, I would say. So you need to figure out who your payer is. Now, this is a question that's come up a lot for me lately. I have, in fact, 4 times this week had people say, well, David, we would refund if this was a Medicare claim, but for private payers, we're not going to refund that money. And I'm often viewed as being very aggressive in saying you don't need to refund money. There are people who have called me a cowboy. I don't actually think of myself as aggressive. I think of it as well-reasoned, and try to be really principled and fair. And this is an area where I'm not going to be aggressive at all. I'm really nervous about the idea of saying we would refund for Medicare but not other payers unless Medicare has a rule that you've prohibited or broken and the other payers don't. In that case, it makes perfect sense to treat Medicare differently than everyone else. But if you have done something that's contrary to what the contract you've entered into says, I'm not very comfortable keeping that money, and I don't feel comfortable treating a private insurer radically different than healthcare. So chalk me up to conservative on that one, and that doesn't make any sense. So the conventional wisdom in healthcare is often wrong. People have incentives to make assumptions in the compliance world either because they don't understand things or because they're trying to push an agenda. All kinds of principles are pushed really hard. Many of you have heard my myths talk. I'm just going to cover really quickly because I think it bears repeating. Whenever you're trying to figure out if you've got a compliance issue, you have to figure out if what you're talking about is a requirement or if it's a guideline. And for Medicare, that hierarchy is clear. You start with the statute, you go to the regulations, and then you go to the manuals. The manuals aren't law. I've had a court of appeals emphasize that to me before when I was trying to rely on the manuals. Ask people to share rules with you in writing and get legal counsel to consider whether the rule that someone is citing is valid. Just because it's written down doesn't mean it's a rule, and just because someone sounds smart doesn't mean they know what they're talking about. I've used this cartoon for years, but I still love it. Relax, Worthington, as the warm, moist air from the jungle enters the cave. The cool, denser air inside forces it to rise, resulting in turbulence that sounds not unlike heavy breathing, which sounds really authoritative until you look at the pile of bones. So investigations are going to keep going. There are so many government investigations right now. My plate is filled with the government some of them are real, but many of them are shakedowns. And it's worth taking time to educate everyone in the organization about the rules and to educate patients so that patients understand the weird nuances here. Because when patients get frustrated, one of the things they often do is report you for fraud. So take time to educate them about the rules you're dealing with. Now, one of the things, I probably should have stuck a slide here, and I'm going to mention it several times. I am a giant fan of intellectual consistency. And I think that we often fail to apply principles consistently. And so one of those is the ones I just talked about. Do you refund on a private payer? If you think that the private payer and Medicare have the same rule and you're refunding for one, how are you going to explain to a judge your choice not to refund on the other? So I've got my first question that's come in. One of my personal favorites. So how does this work for Medicare Advantage plans? That's a favorite topic of mine because it's so difficult. The short answer is no one's entirely sure. I believe that the best answer is that for most purposes, a Medicare Advantage plan is more akin to a private payer than to Medicare, and that the Medicare rules don't apply in the Medicare Advantage context. We've done a fair amount of research on that. I feel pretty comfortable based on A, the research, and B, things that people have said at the governmental level. So I think that that's the right answer. It isn't crystal clear. So if you think about what a compliance plan is, the source of the compliance plan are the federal sentencing guidelines. And so it's a federal law that says if you're convicted of a crime, if you have an effective compliance plan, you get basically a smaller sentence. So this only comes into play after you've been convicted of a crime. Technically, compliance plans aren't used in other settings with one big asterisk, which is the Affordable Care Act included a provision that allows CMS to impose compliance plans on healthcare organizations. CMS has taken advantage of that for skilled nursing facilities, which are now, as of I think March 23rd of this year, required to have compliance plans. Other healthcare organizations aren't required to have one. You don't have to. You simply can. Nursing homes must. For other types of healthcare providers, it's quite possible that we ultimately will have a requirement. The way a compliance plan works operationally is it's a Friday night, and there's a knock on the door of one of your employees, and a person with short hair and an attitude says, hey, what's going on at your organization, and what have they done to comply with the law? And really, you can think of the compliance plan as an internal release valve for people's concerns to get vented internally. I'll talk about this again later, but I'm a big fan of using things like anonymous mail, like a Gmail account or other things, to give people a mechanism where they can report concerns. Now, I'm going to walk us through the 7 elements of a compliance plan, but I am not really stuck on the paper part of this. I think the paper's close to useless. It's really a corporate philosophy. I'm not a fan of policies. I think policies more often hurt than help. For starters, I don't think anyone ever reads them. Occasionally, someone will crack open a policy to find who to call, but operationally, people make decisions based on their instincts, and so compliance is much more about attitudes and getting people thinking the right way and knowing who to call and who to ask than it is about writing up a bunch of documents. I think you pitch the compliance plan to employees as saying, hey, look, your job is to know what you don't know your limitations. If you're not sure about something, look it up, don't guess. When in doubt, ask. We as an organization have a duty to make sure that if you've got a question about whether something is right, we'll answer it. So if you're going to go, what sources of information do you use? Well, Mac bulletins are a decent source. Government websites, except you can't do it during the shutdown. I was just trying to figure out if an area was rural or not, and you can't figure that out because you need the Census Bureau, and the Census Bureau website doesn't work. Lovely. 2 other sources of information I'm a little more skeptical of, and they're trade associations and sort of the popular press. Useful for pointing things out, but boy, I see a lot of mistakes in them. Categorical statements like, you can't bill for services that are incident to if they're done by a nurse practitioner or a physician assistant. That was promulgated for a while by an organization that wanted MPs and PAs to be billing independently. And of course, there's the OIG work plan. So the 7 elements of a compliance plan, as found in the sentencing guidelines, are standards and procedures that reduce the prospect of criminal conduct, oversight by high-level personnel, not giving responsibility to bad people, which are people with a propensity to engage in illegal activities, employee training, a program to monitor and audit, consistent enforcement of your policies through discipline, and then an appropriate response to detected violations. I'm going to walk us through each of these 7 things kind of point by point and try to make some real-world examples. So policies and procedures. I am not a big fan of policies, and the reason I'm not a big fan of policies is I think it's hard to write a good one. I also think that the government often holds you to the standards in your policy as opposed to holding you to the standards in the law. So maybe this is a place, I'm going to use a real-world example. A client called me yesterday, and they said, hey, look, we've got a physician. Some of our physicians don't document. And so we've got no records, and we want to set up a policy that we will refund if documentation isn't completed after 90 days. So there are a whole bunch of issues that a policy like this would create. The first thing is, well, so wait, 89 days is okay? You'll tolerate a lack of documentation for 89 days, and the 90th day is when it's a problem? So there's an issue. There's the question of, well, so now are you saying that a lack of documentation means you need to refund? And we'll talk about the legal elements with that in a while. I would be much more comfortable making a decision on that without writing it up if you're going to do it. I'm not super comfortable with the approach, and we'll talk a little bit more about that in a while too. But how do you write this policy up well? And I'll use an example I've used before, which is if you had asked me a few years ago, David, what do you do if you have a person who makes an intentional misrepresentation of fact? I would have said, well, easy. If someone's intentionally lying, we should get rid of them. And then I had the situation where a physician was told by an insurance company, hey, we won't cover diagnosis A, but if you put diagnosis B, we'll cover it, so put diagnosis B, which is what the doctor did. An intentional misrepresentation. And suddenly I realized that I had oversimplified my thinking. And it's really hard to be categorical. And I'm a policy minimalist. I know people aren't going to read them. My draft compliance plan, and if anyone here is looking for it, it's free. I'll send it out to anyone who wants it. It's about 7 pages long. It's partially because that's about as much as anyone might read. I don't expect very many people to read the whole thing, but at least you've got a fighting shot. So one of the next elements is the what the government calls is avoid giving responsibility to people with a propensity to engage in illegal activities. I think of it as foiling felons. Operationally, this means you should be doing a check of the excluded employee list. And I know a lot of organizations are doing that. The government, I've heard now say that they expect you to be doing that twice a year. I think that's semi-annually. I think that's unreasonable. I don't think folks are going to do it. But certainly when you're at least once a year, and certainly when you hire a new person, you should be looking to make sure that the person isn't on the excluded employee list. I can't count the number of times this has been a problem for our clients. It comes up a lot. And the problem is, if you bill for stuff by an excluded employee, unless you can argue you're without fault, that money's going back. And in order to be able to argue you were without fault, I think you're going to have checked to see if the person was in fact excluded, or have some other weird circumstances afoot. Now, the bottom line is illustrated by this cartoon. Listen out there, we're George and Harriet Miller. We just dropped in on the pigs for coffee. We're coming out and we don't want trouble. The government is going to judge you by the company you keep. And so you want to know if your people are clean or not. Training. Everyone on this webinar does training by definition. You're listening to this webinar. What people I think are often not good about is tracking how much training they do. If you ever get in trouble, one of the things you need to do is convince either the U.S. Attorney or more commonly the Office of Inspector General that you're a good egg. The U.S. Attorney you're trying to convince that shouldn't apply false claims penalties. The OIG you're trying to have them not enforce a corporate integrity agreement on you. I've seen a bunch of situations where good training programs caused the government to say that caused the government to say they weren't going to impose a CIA. So think of a way to make sure that when employees are going to an outside training session, listening to something like this, it's getting recorded in a database. It's an operational nightmare, but it's worth it. This is also a time for training is a multifaceted thing. You're training people to be compliant, but you're also training them not to overreact. You don't want people labeling every mistake as fraud. Most things that happen are mistakes. And I think in the compliance world, we often label stuff as healthcare fraud. The government labels it as healthcare fraud all the time. It's not helping anyone to have panicked employees thinking that every time we have a coding error, it's fraud. And that internal label that you use is often used by the government to try to seek to impose penalties. So part of the training is both helping people understand how important compliance is, but also understanding how important language is. We don't want to exaggerate. We don't want to make problems worse. And this is another place where that internal consistency thing comes up. If you refund money in some situation and you don't in another, you have to be able to articulate why. And that becomes part of training and part of the analysis. So it's okay to be concerned. Panic is bliss. The fuel light's on, Frank. We're all going to die. We're all going to die. Oh, wait, my mistake. That's the intercom light. And the people in the back are a little panicked, but it isn't going to help us at all. Along those lines, so a common question I get, well, do we need coding insurance? And you see individuals who get trained on compliance suddenly think that they're in the crosshairs of the government. And this is a place where one of the goals of training should be to make people feel more comfortable. As part of training, I tell employees, look, there's a concept in almost every state called indemnification that means if there's an investigation and you're an employee, the company is responsible for defending you unless you were acting outside the scope of your employment and were doing something illegal or something like that. The company has your back, and it's important for people to know that so they don't panic. Hey, I just got an interesting question, which is the exclusion list let's see, inclusive of providers throughout the U.S., and the answer is yes, but it also just reminds me, you can check it for free on the OIG website. Oh, wait, you can't now because that website is down because of the government shutdown. But when the government is back up and running, you can for free. You don't need to pay someone to do this. You can totally check for free. So is your compliance thing just for billing? And some people would say yes, because really that's what the sentencing guidelines deal with. I'm a fan of the broad compliance plan for a couple of reasons. I think this is mostly it's a risk management tool. It's about your reputation. And so I think, sexual harassment, while not part of billing compliance, will get you on TV. Dumping your waste out back will, and antitrust. Anything that will get you, it's contributed by this problem here. We've got cat chasing, garden digging, and garbage dumping. And this is the most obscene. I'm a big fan of Gary Larson, and this is the most risque Gary Larson cartoon I have used or seen. Now, if you would all examine the chart, you will notice that, well, it seems that Mr. Sparky has found something more engrossing than this meeting. And if you look at the lower left, Mr. Sparky is sniffing his crotch. And if you've got people sniffing their crotch in a meeting, you want people to know how they should deal with it, and they should deal with it through a compliance hotline as a mechanism. And so I'd let people know that sort of approach. The next element of a compliance plan is that you have to monitor and audit compliance. I put the word audit in quotes because I prefer to use the word review. I think that what you do are reviews and not audits. But in the healthcare world, you want to have a regular process for conducting the reviews. You have to make some decisions. Do you want to have people internally do those reviews, or do you want external people doing it? That's more of a corporate culture question. I guess, who are they going to listen to? The pros from Dover phenomena is well established. There are some people who, for whatever reason, don't listen to people who they know well. They only listen to people that they pay $1 gazillion to on the outside. I guess as a lawyer, I benefit from that sometimes, but I still shake my head at it. I don't understand the principle. I'm a fan of having a good internal review process where you review the reviewers periodically and just make sure that your internal people aren't being too aggressive or too conservative. I do think it's really important to make sure that you're reviewing every type of chart you do. I had a situation once where a clinic looked at its records, but they didn't look at hospital visits. And it turns out the documentation in the hospital was abysmal. And someone just sent me a thing that said the OIG searchable database for exclusions is up and running, which kind of shocks me because Lord knows nothing else I've tried to use is, but thank you for that. When you do reviews, there are people who want to make them statistically valid. I recommend not doing that. It's expensive. Getting to statistical validity is complicated, but I think you're really doing core sampling here. You're looking for problems, and for a bunch of reasons, I am not a fan of spending the gazillions of dollars to get a statistician to look at your reviews. This is another place where language matters. When you have a compliance review, it's easy for people to say, this is fraud. These services aren't documented, which is fraudulent. If you really feel the need to hit someone with a 2x4, the most you might say is the government may characterize these services as fraudulent, which is really different. That's one of the ways choice of language matters is I think you always want to frame things in this is how some outsider might view it, to make it clear you're not necessarily adopting that view. It makes it much easier to defend the situation later on. One of the things you have to do is work with employees to make sure they feel comfortable raising concerns. And I don't have a magic answer for that. Part of it is taking concerns seriously and making sure people feel validated for raising a concern. Even if the concern proves to be an invalid concern, they need to feel like they're not in trouble for raising the question. And the reality is, many of the people who bring this stuff up are, to be blunt about it, difficult. I can think of dozens of situations where a person who's considered to be a pain in the butt brought to forth a major compliance concern. Often it's their 7th or their 8th concern. It's the major cry wolf syndrome. And the only thing you can do is try to make people feel comfortable. You guys know that, so I'm beating a dead horse on this one. But this is something I think people don't always think about. There are some creative ways you can allow people to report concerns, okay? First is the anonymous email structure I was talking about. The reason I like an anonymous email structure is that in theory you can communicate back and forth to someone. I mean, the same is true of a hotline. So hotline is great. You can take things in. But email allows you to get it, think about it, and write back to the person. And you can actually have a correspondence if the person is willing to do so, just using a Gmail account or something like that. So let people know they have that option of, creating an anonymous Gmail account and emailing the compliance officer. Now, one of the biggest dilemmas I have, and I don't know the answer to this, do you want to have many mechanisms for reporting a concern, or do you want clear accountability? So the advantage of many mechanisms, obviously, is you want to give people as many ways to get something into this process as possible. The problem with it is, like, my recommended hierarchy is, hey, go to your supervisor. If that doesn't work, go to your compliance officer. If that doesn't work, go to legal counsel. And I actually give people the outside legal counsel's phone number as a mechanism, or inside legal counsel's phone number as a mechanism to report. Here's the problem. If you've got all of these ways in, it's possible for something to get lost. Real world problem. Person goes to their supervisor, who, in this particular case, they were a nurse manager. You could make them a VP, you could put them whatever level you want. But they go to a management level person who's got authority, and that person says it isn't a problem. Staff figure this person's in authority, they've said it's not an issue, they're done with it. This happened in the mid-90s. The organization was operating unlicensed beds. Actually, it's a little more nuanced than that, so I can understand why the VP actually thought, or the manager thought this was okay. But the end result was, for years, they operated unlicensed beds, and we had a giant overpayment issue to deal with. And I've often thought about, well, what if they hadn't gone to this? The supervisor here was the problem. How do you solve this problem? I don't have a magical answer for it. The closest I can have is the red bullet on this slide. Use a semi-annual certification, or even more often. And that's a form, and once again, we'll send this out free. If you want it, send me an email. Email's on the front page. I'll send you the form right after the talk. It's really short, and it just says, it's 2 check boxes. 1, I'm not aware of any compliance concerns. Or 2, I have the following things I think someone should investigate. So heck, you could either get mine or you can even create it. Either one's fine. But it's a mechanism to ask people to certify that they are or aren't worried about issues. A, it brings issues in, but B, it does something else. Often, when someone says that they have a concern, they will claim to have reported this concern for years and years and years and years. And it's really helpful if someone comes in and says that they've been complaining about something for 7 years, to be able to show 14 copies of a semi-annual certification where they said, no, they didn't have any compliance concerns. And so if you only get one thing out of this webinar, it would be at least twice a year, and you might want to do it more often than that, ask your employees to represent that they have their what they're concerned about. The next thing you need to do is have effective discipline of people. He's using blanks, pass it on. So you need to have some sort of consistent enforcement of your plan. And what this means basically is if someone's not following your rules, they need to have some sort of discipline. That doesn't mean they have to be fired, doesn't mean they have to be taken out back and shot, but some sort of appropriate discipline, both of someone who is making mistakes repeatedly, and then someone who fails to detect a mistake, but who should have. I like to use this cartoon to illustrate it because we've got, and I'm sexist here, I assume that the bear with the number 8 is Mr. Bear, and the other bear is Ms. Bear, which is completely sexist of me, but it's my ingrained assumption. Right again, this had better be good. So what I need to know is to know what the appropriate discipline of Mr. Bear is. Is this the first time it's happened to him or not? And appropriate discipline allows a great deal of judgment. I think of peer review. Peer review isn't a punitive process, it's an education process where you work progressively. You start off with education, and then you do things to get, if someone doesn't take the education seriously, you consider things like financial penalties, which, by the way, you got to check with an employment lawyer before you do that. In a lot of states, you can't just necessarily dock pay automatically. There are, especially in the farm states, often laws against docking pay. You might be able to get around it, but there might be steps you have to take before you can do it. I've seen Saturday school for physicians who don't code properly and things like that. So that's kind of a strategy to use. Just a quick aside, in the compliance world, you're often required to get advice. And when you get advice, it's helpful to think about the fact that you want to get the advice in writing. And since getting advice in writing is extremely difficult, one of the things you want to do is learn to write. If you get advice from someone, write back to them. Send it via certified mail. Dear so-and-so, I just want to confirm that you told me this. Keep that in your file, and you now have documentation, and you've got it framed your way. I am a big fan of that. If you think you have a problem, be very careful asking the government about things. Sometimes you have to call and ask. But if you think you've done something wrong, that's time to use your outside counsel to make the call. This. Well, somehow they knew we were, whoa, our dorsal fins are sticking out. I wonder how many times that screwed things up. You don't want to be a dorsal fin swimming past the government. So, practical real-world compliance issue. You compare your charts against the documentation guidelines and you something like this. What do you do? Now, I'm not going to go into this what do you do in gory detail. The reason I'm not going to go into the gory detail about why, if it isn't written, it wasn't done, isn't the law, is that if you haven't heard me talk about this before, you can go to this link and watch the video. There's an hour-long talk focused on this point. And if you haven't seen it or heard me talk through this, I think it's worth it. If you have, you can skip it. But if you know someone in your organization who doesn't buy the principle that if it isn't written, it wasn't done, isn't the law, you might want to have them watch that talk. But I can't emphasize how much language matters here. So I want to go back to the physicians group I was just working with who has crummy documentation. How are we going to describe the absence of documentation? Like, let's say we write a refund letter. Dear government, we are refunding these charts because we don't have documentation. Well, if that's the letter you write, I think you've just suggested that you believe a lack of documentation creates an overpayment. And that would mean that if you had a situation where you build a 4 and have a 3 documented, that same lack of documentation exists, and you've once again created a legal standard you don't want. So part of your compliance process is thinking about how your interactions with the government work. The letter I would write there would be, dear government, we've determined that we don't have a medical record to support this claim. While we believe that the claim was properly billed, we are choosing nonetheless to refund the money. And there's another webinar we have on voluntary refunds that goes into sort of tips on those, and I think you can find that one on SlideShare as well. But this is something to think hard about because you can make your life more complicated when in an effort to be compliant, you set a new standard for yourself that's to meet. Here's another place where the language matters. Here was my original slide. This is the kind of slide you'd see in all kinds of places. You'd see audit results and undercoded and overcoded. I think there are giant mistakes on this slide that cause trouble. I don't like the terms undercoded and overcoded. I really want to banish them from the healthcare industry. I think all you know is that the documentation exceeds the code that was billed, or the documentation fails to support that was code that was billed, or the documentation supports it. But we don't even know that just because it was documented, it was done, and that's a giant problem in the medical record world. Part of compliance is recognizing you got to be a little distrustful to be an effective compliance officer because of this problem. You've got a patient who's treated by the president of the 70 physician group, calls up and complains that she was billed for a complete physical but never removed any clothes. So if you looked at the medical record and found a complete physical documented, can you end your investigation? You know, because that happened. You start your investigation and you find out, wow, we've got a complete physical. For many people, and I would put myself into many people here, I would have said, great, we're good. Well, in this particular case, we weren't good. Because the people who did the investigation were more cynical than I, and they looked at the doctor's appointment book and found out that the doctor worked from 9 to 3, took lunch, and saw 67 patients. And the lesson here was that sometimes just because it was written doesn't mean it was done. And documentation can be faked. So you need to look at that sort of stuff. So one of the questions you get as part of your compliance plan is, should you quantify exposure? And you run into a compliance dilemma here. If you fail to quantify your exposure, you may not get anyone's attention, right? How do you tell someone this is a big deal if you don't attach a monetary value to it? If you do attach a monetary value to it, how do you not have the government use that against you? The balance I would strike is the following. Here's language, and you could feel free to steal this. If you're doing a chart review, I'd say something like, our chart reviews aren't audits designed to determine whether we've been overpaid or underpaid. They're not a statistically valid sample, and they only review the documentation without attempting to determine the amount of work you actually performed. Therefore, these figures are far from scientific. But since a Medicare review would base the initial overpayment determination solely on the documentation, these figures would give you some idea of how your charts would fare in the first phase of a Medicare audit. And so what you're doing is you're setting up a standard that the government would use and a standard that you would use, and you're articulating them really clearly. I've got a few questions that have come in, so I'm going to try to whip through a couple of those right now. So there's a physician that knows the difference between fraud and mistakes. And when he was confronted, he said he made mistakes and would watch going forward. But he keeps using the same excuse. I'm sorry, I made a mistake. How do you deal with the situation? He's had the same training as all the other physicians. And that's a great question. So my wife is a psychologist, and seems like a total segue, but I'll bring it home, trust me. So she gave me the MMPI, and I come back as my personality type is the personality of a field marshal. And what that means, amongst other things, is that I do not like repetition of error. And the doctor described here is the kind of thing that drives me a little nuts. You're making the same mistake over and over again. I don't mind people screwing up. You got to learn from the mistake. And so what I would tell this doctor is that the definition of a false claim, it's basically something that you do it's intentionally wrong, it's something you do that's willfully wrong, or it's something you do in reckless disregard of the law. And making the same mistake over and over is the poster child for reckless disregard of the law, which means that under the False Claims Act, it's fraud. It's interesting because I would think of fraud as having an intent element, you would think of fraud as having an intent element, but for the False Claims Act, which is different from going to jail, but the intent can be kind of a negligent intent. That's actually not, I've just done a very bad thing there, but the government will view repetition of error as sufficient intent. We would argue they're just mistakes, but that's exactly where the government uses the False Claims Act. What's a hospital's obligation to require its vendors, not employees, to comply with policies and a compliance plan, et cetera? Do we need, that's a great question. Do you need an OIG exclusion list for each vendor employee and how often? So these are wonderful questions. So there isn't, right now, SNFs have to have compliance plans. Remember, a hospital doesn't. So you don't have any legal obligation. I think it's unreasonable, and so I know all kinds of hospitals and stuff like that extend their compliance plans to vendors. I'm not a big advocate for that, because part of it is I guess I do some work for vendors, and you think, how do you say as a vendor you're going to act in accordance with every different organization's plan? You don't even know what they are. What I would expect as a hospital is that the vendor asserts that they have a compliance program, and then what you're really asking is your people to comply with their policies. And then vendors should be, you should ask your vendors to comply with the law, is what I would expect. And I think that's a reasonable expectation. In fact, this is another thing, because you don't want to put a higher standard on yourself. Really, all that you have to do is comply with the law. People sometimes, for example, refer to AdvaMed. I don't want to incorporate AdvaMed into my thing. If I violate AdvaMed, that's not violating the law. So I think I have one more question, and then we will hop back where we were already in progress. So we have a compliance plan that was created in 2009. Have there been enough changes that you would suggest we have it reevaluated? Well, I don't know if it's one of ours. Our form has changed a little bit. And I would say, rather than having it reevaluated, I send the form out to anyone who wants for free. So I would say, if it's our form, yes, because it's free. You might as well. Compliance doesn't change. This isn't about laws. It's about process. And so if the thing you did was good, it should be good today. The question is, was it good then or not? So, all right. So when you think about compliance, what should cause you the most angst? And I want to focus more on process, so I'm going to do this pretty quickly. I am really worried about relationships. Makes me sound like Dr. Ruth or something. I don't know. And so in the healthcare world, if you're a clinic, it's the relationship you have with other clinics or with a hospital. If you're a hospital, it's with your doctors or with a device or drug company. You know, those relationships are most of what get you in trouble. And then, of course, there's the coding problems, the confidentiality snafus, although that's harder to deal with in the, I think that's not as much the compliance world in some ways, although there's a training element in there. So it's really the relationships that cause me anxiety. And this isn't to talk about the Medicare anti-kickback statute, so I'm not going to spend very long on it. But boy, I really worry about making sure people understand that if any purpose of a payment is to influence referrals under the government's one-purpose test, that's a felony. So I've talked about the weakest link a bit, but whenever you're dealing with compliance, you have to think about it only takes one barrier to stop everything. If you've got one person who poo-poos something, it requires a great deal of courage for someone to do an end run around the poo-pooer. And so that's, in some ways, what compliance is all about, is getting people to bring those issues forward. And I don't know that I ever really brought home the question of many entry points or just one. The advantage of many entry points is helping to work around the poo-pooer. The tough thing is if any one of your entry points doesn't check an email or lets it fall off, you can become a victim of, having too many entry points. Make part of your compliance process telling people that they should expect an answer to their compliance concern. And then, so this is a question that comes up a lot, is should you answer someone, if someone raises a concern, should they know the result? And sometimes we worry about telling the result because it could waive the privilege and stuff like that. I am personally a fan of letting people know, thank you for bringing this forward. We've dealt with it and I even would generally say, here's the following ways. We refunded money, or we concluded ultimately a refund wasn't necessary. I think if someone brings a concern forward, they might as well know what you did with it. And then that becomes part of your check, is that hopefully a diligent employee, if they don't get an answer, will bring things forward again. So the last element of a compliance plan is that you need to have an appropriate response to detected violations of the law. Well, heaven knows what it is or where it came from. Just get rid of it, but save that cheese first. My job as legal counsel is helping people save the cheese, all right? If you've been paid for a service, I want to work hard to let you keep the money. So do you need to refund all overpayments? And the answer is, at least for Medicare, clearly now we've got the 60-day refund requirement, which we'll talk about in a second, and it's yes. But the question is, what's an overpayment? And this is where I want to try to avoid phrases like overcoding. Katie and I did a webinar that you can find on SlideShare about what creative defenses to overpayments, where we talk about how you can defend yourself against alleged violations of the conditions of participation. That's what COP is, conditions of participation, not police officers. So there's a whole webinar on that you can watch. You don't refund things that aren't an overpayment. This comes up often enough that I'm going to spend a second on this. There's the requirement in the Affordable Care Act that you refund an overpayment within 60 days of identification. And the question is, when does that clock start running? And that clock starts running after you have quantified the overpayment. And the reason I feel so comfortable about this is twofold. First, the wording of the statute, which is that you have to report and return an overpayment, and you can't return an amount that isn't quantified. And so I think that all by itself should do it. But the other thing is that back in the day when the House and the Senate were talking to each other, as part of the legislative history for this bill, the House bill said that you had to report when you know of an overpayment. The Senate bill is what was adopted, and it had identification in it. And I think knowledge of an overpayment and identification of an overpayment are different. They mean different things. I think you know of an overpayment when you don't have an amount. So if the House bill had passed, I think that the 60-day clock would run from as soon as you know you've been overpaid by something. But identification, I think, requires quantification, and so that's when the clock runs. And I feel absolutely 100% comfortable sticking with this. Someday a rule will come out. I commented on the proposed rule to say I don't think that they have I think that if they try to to say it's within 60 days of knowing there's an overpayment, that they've gone inconsistent with the statute. We'll see what happens with that. And we'll see if the rule ever comes out. Remember that an overpayment is defined as any funds that you receive or retain under Medicare or Medicaid to which the person, after applicable reconciliation, is not entitled under such title. And I want to deal with a couple of things here. One, some people have asked about, what about Medicare Advantage programs? And this is an interesting question here. So if you're overpaid by a Medicare Advantage program, is that money that you have received under Title 18 Medicare? I don't know the answer to this. Katie Ilton and I have spent some time debating this, and it's kind of a fun question if it's not, if you're just thinking about it from an academic exercise. Because I can make the argument that the payment, there's the argument that it's under Title 18 under Medicare is, hey, that money is a Medicare Advantage money. It came from Medicare. It's under Title 18. But the counter argument is that money didn't come from the government. It was, this is going to sound bad, but laundered by an insurance company. And, you know, I'm getting a payment here from an insurance company. And, you know, then I'm going to make the payment to someone else if that money comes to you and then you go buy a copy machine with it. The copy machine didn't get its money from Title 18. We don't have an answer to that question yet, so that one's it's out there. We don't know. But the other phrase I want to pick on is after applicable reconciliation. I think that phrase lets you offset underpayments. And there's been a lot of questions asked about, can you offset underpayments against overpayments? The government has come out inconsistently on that. In the old days, I think it was during the teaching physician hospital report, the Office of Inspector General had a report that let you take underpayments off of overpayments. That's inconsistent, that's inconsistent with some of the stuff they say today. So you need to train people to be aware of mail. And that's not men, but things that the U.S. Postal Service delivers. Anytime you get personalized correspondence, someone's got to be paying attention to that. I hope people are still reading the MAC bulletins, because almost every major investigation is telegraphed by something in a MAC bulletin. And denials. You know, you got to do denial management. And of course, the routine audit should scare you. I have used this slide for years. I love to use this slide, because anytime you see a letter with a bird on it, you want your compliance process triggered. And you want people to know, if you see a letter that comes from, you know, the OIG, the Office of Audit Services, if it's got a bird on it, if it's from an insurer and it's like this, you want to make sure people aren't filling these forms out on their own, that they're sending them properly through the compliance process. So this came out years ago from the Office of Inspector General. This was like in the mid-90s. They were doing a survey about automated hemogram indices. They sent this thing that looked like a survey. And so it asked questions, you know, did you order a complete blood count? And everyone answered yes. Did you request automated hemogram indices? And the answer was no. These were machines that were sold by labs that would say, hey, there's this new thing, this machine will do all these tests, and you can bill for them. And so people saw them as a mechanism to enhance revenue. As soon as you see mechanism to enhance revenue, your antenna should stand a little bit. So I'm going to skip to this next set of questions. Did the lab tell you that these things were automatically included? And I was working with physician-owned labs, and the doctors had no idea what their own lab was doing, which is a little, you know, hard to explain to someone. Yes, we didn't know what our lab did. Let's go to the last question, 4E. Were the indices useful to you in the treatment of the Medicare patient? I worked with about a dozen clients, 11 of whom checked the no box here. The indices were not useful to the treatment of the Medicare patient. Did all of those people just admit that they had submitted false claims to the government? And I'm afraid that the answer is arguably yes. Now, I can put my legal hat on and say, no, there's a hindsight element here. And the question is really, in hindsight, were the indices useful to you in the treatment of the patient? The problem is, for most of the doctors I was working with, it wasn't about hindsight. They didn't understand how to read these indices, and they didn't use them at all in the treatment of the patient. So as those people fill out the form, I think they've just given the government a key tool in a false claims prosecution. And I mention this because of how this survey fits into the compliance process. In many organizations, a receptionist opened the mail and filled the thing out. In other organizations, the receptionist brought it to the doctor, who filled it out, but didn't tell another soul. Sometimes an administrator heard about it. Then one client called me, and if you're thinking, David, how do you know about all those other ones? Well, the reason I know about all those other ones is because when I started using this example in speeches, people would come into me and say, oh my God, David, we got one of those. Was that a big deal? And it's open the gate. It's a big wiener dog. You need to train people that things can look scary, and they need to be used to it. The other thing is, doctors' mailboxes, Katie Ilton is here, and she just wrote me a note that said, doctors' mailboxes go unchecked for weeks, and she's right. We've run into a bunch of things lately where really important communications from the government weren't opened. That's a harder problem to deal with in some ways, but if someone opens it, you want to make sure that that gets through your compliance process. Okay, we'll just skip. So I'm going to end with something we've covered a few times, but I think it's worth doing real quickly. It's what you need to know when the government shows up, and then I'll go through questions. So you need to be prepared for armed agents showing up at people's homes. When should you get worried? If you get a request for one medical record, I'm generally not that worried. That is almost always either just a cert thing, or they're looking at someone other than you. So I would generally say if you get a request for one medical record, you don't need to pick up the phone and call your lawyer, generally. If you get a request for more than one medical record, I'd get on the horn and call your legal counsel right away. And keep in mind, by the way, just a reminder, you may have insurance coverage for outside audits. Many malpractice insurers have riders. If you don't have a rider, there are now policies that cover overpayment investigations, and many places have them. So as soon as an audit starts, the first question you should ask yourself is, do I have a pot of money available to me for this? The list of organizations that can darken your door includes, the OIG, the FBI, Mafuku, the Medicaid Fraud Control Unit. So all of those folks. Part of your compliance process is making sure people know how to react to a phone call from an outside person. They will forget. You need to do this training periodically. They'll forget and they'll panic. If you've never heard this talk before, remember, we have little laminated cards that are what you need to know if you're contacted by a government agent. We'll send those out for free. You can give them to whoever you want and use that in concert with training. So you need to know how to get a hold of people at weird hours. For whatever reason, it seems to be Thursday night is the most popular night for the Office of Inspector General to show up at people's homes. I used to wonder if it was because of must-see TV on NBC. But the OIG, if they get really interested in you, they will visit people at home at night at 7 o'clock in the evening. So you react to things. If it's a letter, you want to know who sent it. Make sure you keep a copy of everything you send back. And we can't stress this enough. People often think, oh, we're just sending medical records. We already have the medical records, so we're not going to keep a copy. But routinely, you think you sent everything, but somehow, radiology interpretations didn't get sent, or something goes wrong. You want an exact copy of what went in ideally with what us lawyers refer to as Bates numbers, which is a number stamp, so that you have this page went. If nothing else, you can use it when, you send the thing in to one of the government contractors and they claim that they never got it. You can say, look, here's the list of the pages, and you'll be able to prove it as they tell you that they've never seen things. Telephone calls are pretty rare, and I actually would be skeptical of phone calls from someone purporting to be from the government. You should call back. If you don't know who the person is, don't trust that the person is authentic. You can see phishing in this sort of stuff. And so if someone calls in looking for things, it is not unreasonable to, don't call the number they give you, but if they claim that they're from the local Office of Inspector General, you'll look up the Office of Inspector General in the phone book and call the number back. We have twice had situations where people purported to be a government agent. So paranoia here is warranted. This has to be part of your compliance training. I had a surgeon who said, David, I've got a deposition request for a malpractice case, take care of it. And he sent me a document. The document wasn't from a malpractice case. It was a grand jury subpoena. This is what it said. The United States Attorney requests you don't disclose the existence of this subpoena. Any such disclosure would impede the investigation being conducted and thereby interfere with enforcement of the law. So the good news is that my surgeon was in a hurry and he didn't read the subpoena. That's why he thought it was a malpractice thing and didn't see that it was from the U.S. attorney in Atlanta. Had he read this, there's an interesting question. Would he have sent it to me? Because if you read this and take it literally, you can't tell anyone you got it. There's a pretty strong argument that this information is unethical. In fact, it came up at the Bar Association. They have been complaining about the government including information like this. But you need to know that sometimes the government will tell people, I'd appreciate it if you didn't tell anyone about this investigation, because as it says here, it'll impede the investigation. That causes people to think that it's illegal to tell someone about the contact. So an important part of your compliance training is to say, if you're ever contacted by the government, you have an absolute right to tell us about that, because the only time the government can prevent someone from talking about a contact, there are a couple of government statutes, but they're very limited, and they involve terrorism investigations and then some weird, obscure banking stuff. But nothing that's going to come up in the healthcare compliance arena that permits the government to put you on lockdown. And it's really important to inoculate your employees before they get the visit. So part of your compliance should be, here's how to interact with the government. And the last few points on that. So if they show up, if they have a warrant, you have to let them in. Remember, Medicare has a right to immediate access, which is defined as within 24 hours. So actually, immediate access doesn't let them in, but a warrant would. And immediate access just gives, they have the right to records within 24 hours. You don't talk to the agents when they show up, which doesn't mean you pantomime everything, but you don't engage in any discussion on the substance. You get their business card and you get on the horn with the lawyer. The agent is going to take the beware of dog sign and replace it with the dog okay sign, telling you how this isn't a big deal. And they'll tell you things like, oh, you don't need to talk to a lawyer unless you've done something wrong. And they'll give you all kinds of other lines that are lines. They expect you to call legal counsel. And I mean, I think most of you on this know this, but this, you have to get people used to the idea, because they think if they say to the agent, I want to consult with legal counsel, that is a giant admission of wrongdoing, and it's really hard for people to do it. One of the challenges is, as you do that, you can't tell them not to talk to the government agent. We'll come to that one in just a second. So the agents are really good at using fear and confidence, and or silence. They'll sit there quietly, and it makes people talk. There's a case out of Michigan where a doctor said, my lawyer told me this was okay. That statement waived the attorney-client privilege, and the government was able to see all the communication between the government, between the lawyer and the doctor. You really want to train your staff that if a government agent shows up, they don't have to talk. You can't tell them they can't talk. You just want to tell them you don't have to talk. We'll provide you with legal counsel. So here's what you should do. Get their business card and tell them we'll get in contact with them and arrange a time to talk. The agents will try things like, we'll be mad. They'll do the, okay, I'll go back in the boat and I'll go back and tell my people you're staying in the boat, but I warn you, they're not going to like it. The agent will say, you're not going to talk to me? Well, that's going to make me mad. You can either jump into the water, i.e. talk to the agent, or stay in the boat and have a mad agent. I know which one I would choose. So the government doesn't have the ability to make people attend interviews. They can't get documents without a warrant or a subpoena. They can't get privileged information, and they can't prevent people from talking about the interaction. But something you can't do, you can't tell employees not to talk to the government. And so you can only tell them, we'd request that you get legal counsel involved first, but you can't require it. Obviously, you want to make sure employees, if they talk, they do tell the truth, because that's the number one thing that gets people in trouble, and you can't destroy and hide documents. So I think we have a couple more questions here. Let's just see what we got. So, well, here's one that stumped me, and Katie Ilton is nearby. Maybe she'll know this one. I don't know if I'm gonna. So the question is, it's my understanding that high-tech requires that vendors and their employees comply with the covered entity compliance plan for HIPAA. Well, this is kind of, I am not our HIPAA guru. I don't know this one. I'm going to punt.
I'll weigh in just for 30 seconds. So the new HIPAA rules in high tech from 2010 say that business associates have to follow certain privacy and security requirements to protect protected health information. It doesn't say that the business associate has to follow the covered entity's exact HIPAA compliance plan or their broad compliance plan, but there is magic language they have to sign as part of the business associate agreement that says they have to follow certain parts of HIPAA.
Okay, thank you, Katie. It's good to have people smarter than you nearby at all times. All right, I got a couple of really good ones here. So we think we have an overpayment, but it would cost a lot of money, much more than the possible overpayment, to investigate. Do we have a duty to investigate? You know, I would say you don't have a duty to investigate. What I'd do in that situation is, if you got any doubt, you refund the money, and you just say, hey, look, we're not sure if there's a refund to do here or not. Here's the money. We're not, and I'd lay it right out. We're not going to look at this. Here's the amount involved. We'd rather just refund the money. Here it is. I think that's, so I think you do that or investigate. I don't like the saying it's too small. I'm not a big fan of, well, at least if it's governmental stuff, the de minimis principle doesn't work so well. If it's private pay, it's a little more nuanced. Now some of you are saying, David, you hypocrite. I thought you said you have to treat everyone the same. And first of all, no, you don't have to treat everyone the same. You have to treat everyone consistently with their rules. And there is a federal statute that says whoever has knowledge of an event affecting their initial or continued right to any benefit or payment under a federal health care program who conceals or fails to disclose the event with an intent to fraudulently secure the benefit is guilty of a felony. And it scares me that is still in my mind after all these years. That statute has never actually been enforced, but it's out there and it scares me. And it makes me think that if you owe the government even a penny, arguably they can use that statute against you. There isn't a comparable statute for private insurers, and so that's where I could see some possible but I'm not a fan of, I would say, when in doubt, if you're not willing to look, just refund. So we had a disgruntled departing physician who made some compliance allegations against the organization on the way out the door. Now this is obviously totally made up. A former employee making compliance allegations? Jeez. He said he'd forget the allegations if we paid him a lump sum. I'll give him a Do we have an obligation to investigate his allegations? Well, obligation? I mean, are you legally required to? No. Would I, if I were in your shoes? Darn straight. Because I believe the technical term for that person is whistleblower. You want to know what's going on. And so you're going to want to look into it, which is different from a legal duty. An interesting question, is his making a demand that you pay him and he'll forget that extortion? And the answer, I think, is yes. I think that actually is extortion. And if you really wanted to do so, I mean, I remember getting raised voices once with a local plaintiff's attorney on that thing, as the plaintiff's attorney said that if we gave him if we gave his client $350,000, she would not go all qui tam on us. Can you make an employee tell you what the government agent talked to them about? No, you can't. I mean, you can't really make anyone do anything. You can ask, but you can't make them. Let's see. What's the best way to complete exclusion reviews on companies and their employees that perform coding? So what's the best? I am still a fan of the free OIG website. As an aside, I learned an interesting lesson a few years ago when there was a rumor that one of our employees had a criminal sexual conduct conviction. And my job was to figure out if it was true. Holy cow, it is hard. Ultimately, you had to know the county in which the conviction occurred. A lot of what you think of as background checks aren't terribly effective, is one of the lessons I learned here. But the exclusion list you can do for free, and you can do it at the OIG. There are also vendors who will do it, and you can pay. I don't know how much it costs, but since, and if you're giant, it may be lots of names, but if you have an assistant who can type the names into a list, you can do it, and the OIG website is free. So, to close this out, we went a couple minutes over. Remember, November 13th, Carrie Rosenberry and Briar Andreessen are going to talk about all you need to know when negotiating EHR contracts. You can watch this and our other talks at SlideShare. Once again, Robert will send the link out here. SlideShare's website isn't the